The single field analysis printout is divided into 11 zones. The zone 1 is patient data, test data. The information that is present in the proforma must be entered accurately. Zone 2, the reliability data. The false positives, if they exceed 15%, the test should be repeated. In the gray stacking, it should be studied. The upward spike indicates eye movement. The downward spike movements blinking. Zone 3 is raw data. It is the measured retinal sensitivity in dB values. Higher the values, higher the retinal sensitivity. A 0 with inferior sign indicates absolute scotoma. A numerical value other than 0 with inferior sign indicates the bulb is becoming dim and it should be replaced. Always concentrate on the central 16 points, the retinal sensitivity. If there is a reduction, you ask for the test to be repeated with 10-2. Zone 4 is the grayscale. It is the shade format of raw data. The darker the shade indicates the lower sensitivity. The multicentric origin of glaucomas are better appreciated in the grayscale, and disappearance of brightness in the central area may be the early indication to repeat the test with 10-2. Zone 5 is the total deviation numerical plot. If the measured retinal sensitivity and the normative data are same, then the 0 will be there. And if the measured retinal sensitivity is better than normal, then no sign in front of the numerical value will be there. And for loss of retinal sensitivities, a minus sign will appear in front of the numerical values. So loss of retinal sensitivity, now they are converted into scotomatous form depending upon the p-value. Usually the loss of retinal sensitivity more than 8 dB will have a p-value less than 0.5%, and hence it will be represented by a black square. So a black square in the total deviation probability plot does not mean that it is an absolute scotoma. It only indicates that its p-value is less than 0.5%. In the case of cataract, there is a loss of retinal sensitivity at around 8 dB. So all the points will have black squares in the total deviation probability plot. If this patient develops a localized scotoma, either due to glaucoma or due to any neurological condition, this localized scotoma will be masked in the generalized depression. So to highlight the localized scotoma in generalized depression, the pattern deviation probability plots are created. In the case of glaucoma, we will see sometimes all the spots with black squares and without any cataract. Then the deep scotomas are highlighted in the probability plots, and the superficial scotomas, they disappear, from which we can know the direction of progression. In this case, it is progressing towards the fixation and also going away from fixation. Now coming to the global indices, the mean deviation index tells about the depth of the scotoma, and it is the average of all the points of total deviation numerical plot. Whereas PSD, it tells about the index developed to tell the contour, and it is the index developed to tell early localized scotoma. It is nothing to do with the depth of the scotoma or severity of glaucoma, and there is no sign in front of it. Take for example, this glaucoma patient develops cataract. There will be change of mean deviation from -3 to almost around -12. But because there is no change in contour and it is a uniform generalized depression, there will not be any change in PSD. The visual field index, it tells about the percentage of the vision existing. The normal is 100%. If there is a loss by 10% of vision, then the 90% VFI will be there. And this index is also used in guided progression analysis as a base unit. Please note that VFI is not calculated in 10-2 program. Hence, guided progression analysis cannot be applied to 10-2 program. As you know, there is a disparity of retinal sensitivity on either side of horizontal axis in glaucomas, which is a hallmark of glaucoma. That concept is used to and developed visual field, the semi-field test to identify glaucomas at a very early stage. in the role of visual fields in a glaucoma suspect is the diagnosing glaucoma. These things most important is the elimination of artifact and also see that localized scotoma is fulfilling Anderson's criteria or not. The localized scotoma should always correlate with fundus, and since Anderson's criteria includes the localized scotoma should be at least 3 points. There should be non-edge points of 30-2, and they must be cluster points, and at least 1 point will have a p-value less than 1%, and 2 points p-value less than 5%, PSD with a p-value less than 5%, and JHP outside normal limits. If they fulfill, then this localized scotoma can be labeled as glaucomatous once it correlates with the fundus. And then the role of visual fields in established case of glaucoma is to set the target IOP. To set the target IOP, we have to analyze the localized scotoma under the following factors: the location of the field defect, extent of the field defect, and direction of progression of the field defect, whether it is going towards the fixation or away from fixation, and what is the depth of the field defect, and whether it is a relative scotoma or absolute scotoma. So all these things will help taken into criteria to set the target IOP. Identification of multicentric origin of glaucoma and when to repeat the test with 10-2, they are also very important, and how often the test should be. One should know the indications for 10-2 point pattern. Well, almost 24-2 is almost looking normal. In this case, the most important is first you see the probability plot. In the probability plot, if you see significant these scotomas within 10-degree area, or grayscale if there is a disappearance of brightness in the central area. The third one, if the RNF field defect is going towards the macula. In OCT, the thinning is going towards the macula, and in the raw data, among the central 16 points, if there is a gross reduction or a significant reduction, even at a single point, there should be taken into consideration to repeat the test with 10-2. So my sincere thanks to Maharashtra Ophthalmic Society for giving me the opportunity to share my knowledge with you all. Thank you.